Hey all, welcome back to the Real Life Pharmacology Podcast. I am your host, pharmacist Eric Christensen, and I thank you so much for listening today. Go check out reallifepharmacology.com. Grab your free 31-page PDF on the top 200 drugs. Great resource if you're out in practice, just a quick refresher, or if you're going through pharmacy school, nursing school, med school, or some other school that you have to take pharmacology. It's a great resource for you as well. So again, reallifepharmacology.com, your free 31-page PDF on the top 200 drugs. All it takes is an email to sign up and get that absolutely for free. All right, so let's get into the drug of the day today, and that is Losartan. We have covered ARBs in the past, but I wanted to talk about a few specifics because I have had a couple of people reach out over time and ask specifically about Losartan. So let's get into that. Brand name is Cozar, and it is, I would say, probably the most common ARB you're going to see. So what's an ARB? An ARB is an angiotensin receptor blocker. So essentially what this drug does is it blocks the action of angiotensin II. And if you remember, angiotensin II is a potent vasoconstrictor. So by blocking that or preventing it from binding to its receptors, it's going to cause vasodilation. And with vasodilation, you get a drop in blood pressure. So its major and most common use is going to be the management of hypertension. Now, with that said, it does have a significant number of other uses. So, post-MI, acute coronary syndrome, you will definitely see an ACE inhibitor or an ARB like Losartan used in that situation. Heart failure, chronic reduced ejection fraction heart failure, definitely going to see an ACE or an ARB utilized there. Again, an ARB like Losartan. And then proteinuria with CKD. So kind of reducing that, preventing that, delaying progression. You're going to see Losartan used for that as well. So, and often this is used in combination. So it's used to basically kill two birds with one stone, where we're managing, let's say, heart failure, and we're also helping to reduce the blood pressure there. Now, one unique indication, I did actually see it the other day. It's not very often, but Losartan has been associated with lowering uric acid levels. And if you remember what uric acid, when that's high, patients are more at risk for gout or gout flares. Okay, so now, would you specifically use Losartan over allopurinol, let's say, to lower uric acid? No, you likely wouldn't. But if you've got a patient with gout and you know they have had flares in the past, and they've got high blood pressure, it's definitely a consideration that you might reach to Losartan first compared to let's say amlodipine or chlorthalidone or hydrochlorothiazide or whatever other drug, lisinopril. You might reach for that Losartan first if you can potentially help lower uric acid a little bit there. So kind of a unique indication that I definitely wanted to get in here on this podcast. All right, so dosing is another question that I've definitely been asked about before. So the most common dosing is going to be 25 to 100 milligrams once daily. That's definitely the most common dosing that I see to manage blood pressure and potentially some of those other conditions as well. If we're managing hypertension, usually what's done is you start the drug, let's say 25 milligrams is your starting dose, and you monitor blood pressure, obviously. And we're going to monitor some lab work as well, which I'll get into in a little bit here. But usually it's in 2 to 4 week intervals that we're managing blood pressure medication changes. So if the blood pressure still isn't at goal or where you want it to be, we'll double the dose, bump it up to 50, and then potentially double it again up to 100 based upon the response on blood pressure there. So that is the most common dosing you're going to see. However, The dose will be, and there is some evidence for this, you will see it pushed up to 150 milligrams at times. And the most likely indication that that's going to be used, that higher dose of 150 milligrams, is heart failure. So that's definitely a kind of a deeper end clinical nugget with Losartan there, in that target higher dose is probably going to be most associated if you've got a patient with reduced ejection fraction heart failure. All right, let's get into adverse effects. Hopefully you're familiar with ACEs and ARBs. In general, incredibly common class of drugs that are utilized, but let's talk about the adverse effects of Losartan here. So increased potassium is always one of the first things I look at, okay? So making sure we're monitoring potassium levels, and you want to also think about other drugs, which I'll get into in drug interactions, that may raise that potassium level as well. Of course, Losartan lowers blood pressure, so we've got to think about, potentially additive effects with other agents and monitor that blood pressure, of course. Angioedema, so pretty rare consequence or adverse effect with Losartan, but it can happen. I have seen it happen. And if you ever have an exam, that type of thing, ACEs and ARBs are usually at the top of the list as far as drugs that can most frequently cause it, even though it is relatively rare, in my opinion. Renal impairment can happen. So what you're going to see here is likely a rise in creatinine. That's usually one of the main markers that we monitor for renal function. And so if you see that going up, that could be indicative. And we've got lots of other drugs, I'll talk about in drug interactions, that may increase that risk for renal impairment. And then I did want to mention cough. I have had people reach out to me about that before. Can ARBs cause cough? And if you look in the package insert, it is reported as a possibility. But certainly it's going to be much, much less frequent than an ACE inhibitor. So generally in practice, what you're going to see is if somebody starts lisinopril or another ACE inhibitor, ramipril, whatever it may be, they get a cough, then we're going to generally switch them over to an ARB like Losartan, which generally is going to have a much lower incidence of cough. All right, a couple of special populations I wanted to mention. So pregnancy, we're generally going to avoid an ARB like Losartan in pregnancy. There's risks to the fetus and things like that. So avoid Losartan in pregnancy. We have some other hypertension agents that we might use there. Black patients may not respond as well to the ACEs and the ARBs, and Losartan's obviously included in that. So that's important to note as we're, starting a medication, increasing the dose. Maybe you're not seeing that response. That could be a potential reason why we're not seeing that response. Monitoring parameters, potassium I mentioned, that could go up. Blood pressure, we're going to obviously monitor that. And we're also going to monitor kidney function. So again, that creatinine, which I mentioned. All right, let's take a quick break from our sponsor, and I'll wrap up with drug interactions. If you're in the market for pharmacist board certification study material, like ambulatory care, pharmacotherapy, geriatrics, psychiatric exam, BCMTMS exam, NAPLEX, go check out meded101.com/store. Your purchases there go directly to support this podcast, help keep it free and educational for all to benefit from. Also, if you're a nurse, other type of healthcare professional, PA, nurse practitioner, physician, we've got a growing list of books and resources at meded101.com/store, S-T-O-R-E. Lots of case studies, clinical pearls, great resources for yourself as a practicing clinician or potentially a student that you may have on rotation that needs to beef up on their medication education. So again, go check out all those resources, meded101.com/store, S-T-O-R-E. All right, so finishing up with drug interactions. First, I wanted to mention the CYP enzyme pathways. And Losartan really isn't going to be strongly impacted by any CYP interacting enzymes, okay? It's probably not going to lead to any type of clinical significance if that does happen. There's a couple enzymes that, may kind of mess up with the metabolism and the pathway and that type of thing, but by and large, it's not an incredibly strong interaction, in my opinion. So with that said, mostly what I'm concerned about is additive adverse effects. So first one and most obvious is lower blood pressure. So you get your non-antihypertensive medications that lower blood pressure, your PDE5 inhibitors like sildenafil, your dopamine agonist type agents, maybe a Sinemet, those type of things. Those drugs can lower blood pressure, and they can have an additive effect, obviously, on top of losartan. Next drug interaction I want to talk about, a fairly common one. Generally, it doesn't lead to significant issues, but if we cause acute renal failure, that's a really, really big deal, okay? And we're a lot more likely to do that when a patient is taking losartan with another kind of kidney impairment agent. So NSAIDs, commonly used over the counter, definitely we run into that a lot, where NSAIDs and an ACE or an ARB combined together can increase the risk for renal impairment and acute renal failure. Another class, diuretics, loops, thiazides, they all can potentially worsen, exacerbate dehydration risk, and potentially lead to acute renal failure. Another one, maybe more hospital-type setting, aminoglycosides, where we're doing an infusion there with, gentamicin, something like that. Those can definitely cause some nephrotoxicity, and added on top of other agents like losartan that can do that. It's something we're going to have to monitor closely. And then lastly, I definitely wanted to mention the additive effects of hyperkalemia. So ACE inhibitors are not supposed to be used with losartan, okay? We don't ever use ACEs and ARBs together, okay? That's a very important thing to think about. I have definitely seen it in combination in practice, whether that was an error or an oversight by a provider, that type of thing. I definitely have seen it, so pay attention. But there are other agents where you might use losartan with them. So the first one I think about is, especially in something like heart failure, losartan may be utilized, and a drug like spironolactone might be utilized. Both these meds can increase potassium, so we got to make sure we're not getting to a significant hyperkalemic state. And then the last one I wanted to mention was trimethoprim. So trimethoprim, usually most commonly used as part of Bactrim. So that's sulfamethoxazole and trimethoprim. That can raise potassium levels. And I've actually seen drug interaction happen where a patient was on an ACE or an ARB with trimethoprim, and potassium levels went up above 6, definitely getting to more of the dangerous type level. So again, definitely remember trimethoprim, an antibiotic for infection, can raise potassium, and especially likely, or more likely, in a patient taking an ARB like losartan. All right, well, that's going to wrap up the podcast for today. Thank you so much for listening. If you enjoyed this episode, leave a rating, review on iTunes, wherever you're listening. Email us to classmates, colleagues, students that you're working with. Definitely help us share the podcast with all who may benefit from it. If you want to reach out to me, mededucation101@gmail.com, or you can track me down on LinkedIn, Eric Christensen, PharmD, BCPS, BCGP. I thank you all so much for listening. Take the time to support the sponsor, meded101.com/store. And of course, as always, share this podcast with your friends and colleagues. Take care, and I hope you have a great rest of your day.